Good morning. This is the lecture for problems of hemostasis as related to cancer. We will also be reviewing leukemia, lymphoma, and multiple myeloma. Bone marrow suppression or myelosuppression is one of the most common effects of chemotherapy, and to a lesser extent, it can also occur with radiation. Treatment-induced reductions in blood cell production can result in life-threatening and distressing events for your patient. These can include infection, hemorrhage, and an overwhelming feeling of fatigue. The major differences, as we discussed when we talked about the cancers for Chapter 16, is that the manifestations between radiation therapy and chemo is that with radiation, because it's a local therapy, only bone marrow that is within the treatment field is affected, whereas with chemotherapy, it affects the bone marrow function throughout the body. Therefore, the effects are more profound with chemotherapy and also when the two therapies are combined. When we look at thrombocytopenia, this is a reduction of the platelets below 150,000 for your patient. Acute, severe, or prolonged decreases from this normal range can result in abnormal hemostasis that can manifest into bleeding from minor trauma or actually spontaneous bleeding without injury. Platelet disorders can be inherited, but the vast majority are acquired. A common cause of acquired disorders is the ingestion of certain herbs or drugs. Although some agents are directly myelosuppressive, such as your chemotherapy agents. The usual mechanism of thrombocytopenia caused by herbs or drugs is accelerated platelet destruction caused by drug-dependent antibodies. These antibodies actually attack the platelets when the offending agent binds to the platelet surface. You need to do a careful review of the patient's history, which will help to identify their cause or the cause of the thrombocytopenia. For example, quinine is in tonic water and in many herbal preparations. In addition, some drugs can affect platelet aggregation. Low-dose aspirin is one of these drugs that we utilize to alter the platelet aggregation. Many patients with thrombocytopenia are usually asymptomatic. The most common symptom that you will see is bleeding, usually in the mucosal areas or cutaneous. Mucosal bleeding may manifest as epistaxis and gingival bleeding, and large bullous hemorrhages may appear on the buccal mucosa because of the lack of vessel protection by the submucosal tissue. Bleeding into the skin is manifested as petechiae, purpura, or superficial ecchymosis. Petechiae are small, flat, pinpoint, red or reddish-brown microhemorrhages. When the platelet count is low, red blood cells may actually leak out of the blood vessels and into the skin to cause petechiae. When petechiae are numerous, the resulting reddish skin bruise is called purpura. Larger purplish lesions caused by hemorrhage are termed ecchymosis. The patient's ecchymosis areas may be flat or raised. Pain and tenderness sometimes are present in these areas. Prolonged bleeding after routine procedures such as venipuncture or IM injection may indicate that the patient is has thrombocytopenia. Because the bleeding could be internal, you must be aware of the manifestations that reflect this type of blood loss, including weakness, fainting, dizziness, tachycardia, abdominal pain, and hypotension. There are some major complications of thrombocytopenia, one of which is hemorrhage. The hemorrhage could be insidious or acute. It could also be internal or external. It can occur in any area of the patient's body, including the joints, retina, and brain. Cerebral hemorrhage may be fatal for your patient. Insidious hemorrhage may first be detected by discovering the anemia that accompanies that blood loss. Because thrombocytopenia can be accompanied by vascular thrombosis in some of the disorders, signs and symptoms of vascular ischemic problems can manifest. For example, the patient could have signs of subtle confusion, they can complain of a headache, or even serious manifestations such as a seizure or coma may be seen. Because some of these signs and symptoms may be subtle, astute and thorough assessment of the patient is essential. Collaborative care of thrombocytopenia differs based on the etiology. Either removal or treatment of the underlying cause or disorder is sometimes sufficient. The patient with thrombocytopenia should avoid aspirin and other medications that affect platelet function or production. Again, as care is based on the identifying cause, we can either remove the identifying cause, such as if it's drug-induced, but if needed, we can also treat the patient with corticosteroids if there is an unidentified precipitating factor, and also they could have to have platelet transfusions if they have a life-threatening hemorrhage or when the platelet count is extremely or critically low. When we look at leukemia a little bit later, be aware that all blood cell types may also be depressed by the treatments that are done and by the actual disease process itself. Chemotherapeutic drugs also, again, we've already discussed, cause bone marrow suppression. And with supportive treatment, we can help the patient resolve their thrombocytopenia. When the platelet count is decreased in thrombocytopenia, however, prolonged bleeding from trauma or injury does not usually occur until the platelet count drops less than 50,000. When the count drops below 20,000, spontaneous, life-threatening hemorrhages can occur. Bone marrow analysis is performed when other tests are inconclusive, and especially in older adults because of a higher suspicion of an underlying bone marrow disorder. When it is suspected that there is destruction of circulating platelets, the analysis will show megakaryocytes, which are the precursors of platelets, to be normal or increased, even though the actual circulating platelets are reduced in the patient. You will want to do PT and PTT on these patients. They will need a CBC with differential and platelet count and a peripheral smear for exam to identify the megakaryocytes. And you also want to do an entire clinical history and exam on the patient in order to identify the underlying cause. Your nursing assessment is both subjective and objective. You're going to look at their past health history, their medications that they have been on, and their normal functional health patterns. The objective data that you will notice: does the patient have any fever? Do they have lethargy? Bleeding? Is there splenomegaly? Do they have abdominal distension? Is there petechiae or purpura present? And also a review of the overall lab data. Please review Table 3114 for your assessment or collaborative care information. Your overall goals for your patient that has thrombocytopenia is that they will have no gross or occult blood or bleeding. maintain vascular integrity, and manage home care to prevent any complications that could be related to an increased risk for bleeding. Health promotion, we need to definitely discourage our patients from the use of excessive over-the-counter medications that could cause or acquired thrombocytopenia. Aspirin, of course, we know reduces the adhesiveness of platelets and can contribute to bleeding. Encourage persons to have a complete medical evaluation if they have any manifestations of bleeding tendencies, prolonged epistaxis, or if they start noting petechiae. Observe for early signs of thrombocytopenia in the patient who is receiving cancer treatment drugs. Your vigilant assessment is very important for these patients. In our acute intervention, the goal during this is to prevent or control hemorrhage. In the patient with thrombocytopenia, bleeding is usually from superficial sites. However, deep bleeding into the muscles, joints, and abdomen usually occurs only when the clotting factors have been diminished. You need to emphasize that a seemingly minor nosebleed or a new petechiae may actually indicate a potential hemorrhage, and the healthcare provider should be notified. Bleeding from the posterior nasopharynx may be difficult to detect because the blood may be swallowed. It is important to avoid IM injections with these patients. However, if a subcutaneous injection is unavoidable, the use of a small gauge needle and application of direct pressure for at least 5 to 10 minutes after the injection has been completed, or the placement of an ice pack, may be helpful. Help the patient to understand the importance of the adherence of their own self-care measures to help reduce the risk of bleeding. You need to teach your patient what they need to monitor, such things as black, tarry, or bloody bowel movements, black or bloody vomit, sputum, or urine, their actual bruising or small red or purple spots on the skin, bleeding from the mouth or anywhere in the body, headache or changes in how well they can see, difficulty talking or sudden weakness of an arm or leg or confusion occurs. They need to know about any restrictions in their normal activities, such as should they not be doing vigorous exercise, lifting weights. Generally, walking can be done safely and should be done with sturdy shoes or slippers. If the patient is weak or at risk for falling, they need to get help or have supervision when they're getting out of bed or a chair. They are encouraged not to blow their nose forcefully, to gently pat it with a tissue if needed. For a nosebleed, they need to keep their head up and apply firm pressure to the nostrils and bridge of the nose. If the bleeding continues, place an ice bag over the bridge of the nose and nape of the neck. If they are unable to stop the bleeding after 10 minutes, they need to call their physician or go to the emergency room. They are not to bend down with their head lower than the waist, and to prevent constipation by drinking plenty of fluids. That way they are not straining when they're having a bowel movement. They may need to have a stool softener prescribed for them to help. They're not to use a suppository, an enema, or a rectal thermometer without the permission of the healthcare provider. If the patient has thrombocytopenia, they should only shave with an electric razor and not use regular blades. They're not to pluck their eyebrows or other body hair. Avoid any puncture of the skin, such as getting tattoos or any body piercing. And again, avoiding using medications that can prolong bleeding or any other herbal supplements that may cause thrombocytopenia or decreased platelet aggregation. Use a soft bristled toothbrush, which will help prevent injury to the gums. Flossing is usually safe if it is done gently using the thin tape floss. They are not to use any alcohol-based mouthwashes since they can dry the gums and increase bleeding. Women who are menstruating should keep track of the number of pads that they use per day. When you start using more pads per day than usual or bleed more days, they need to notify the healthcare provider. They are not to use tampons. They are only to use sanitary napkins. And also, they are to check with their healthcare provider before having any invasive procedures done, such as dental cleaning, a manicure, or a pedicure. In regards to females, suppression of menses with hormonal agents may be indicated during predictable periods of thrombocytopenia to help to reduce the blood loss from menses. Examples such as during chemotherapy and hematopoietic stem cell transplantation. And to give an estimate of about how much blood loss there is in a sanitary napkin, a loss of 50 mLs of blood will actually completely soak a sanitary napkin for women. When we look at administering platelet transfusions, we need to avoid developing a complacent attitude about this common but potentially dangerous therapy. You need to make sure that the physician has discussed the risk, benefits, and alternatives with the patient, and that this is documented in the patient's medical record. Traditionally, the term blood transfusion meant the administration of whole blood. Blood transfusion now has a much broader meaning because of the ability to administer specific components of blood, such as platelets, packed red blood cells, or plasma. Usually a specific component is ordered, although when you have a massive hemorrhage or if there is a need for exchange transfusion, whole blood can be used. It is important that the patient's platelet count, coagulation studies, hemoglobin, and hematocrit are closely monitored throughout any therapies. Together, these provide the most important information regarding the potential or actual bleeding that can occur. For a patient who's going to be cared for at home, it is important, again, that they know how to monitor themselves for the response to therapy. You need to teach the person who has acquired thrombocytopenia to avoid any causative agents when possible. Please refer back to Table 31:12. If the causative agents cannot be avoided, such as someone who has to have their chemotherapy, teach the patient about avoiding any injury or trauma during these periods and to be aware of the clinical signs and symptoms of bleeding that can be caused by thrombocytopenia. Again, as discussed earlier, but also you can find in Table 31:16. Patients with either ITP or acquired thrombocytopenia should have planned periodic medical evaluations to assess their status. These regular evaluations can be used to assess and treat situations in which exacerbations and bleeding are likely to occur. The impact of either an acute or a chronic condition on the patient's quality of life should also be addressed appropriately. For patients who have a acquired thrombocytopenia, especially when it's related to chemotherapy, the administration of interleukin-11, which is a platelet growth factor known as Numega or Oprelvacin, is given to the patient. However, there are side effects. There can be fluid retention, peripheral edema, dyspnea, tachycardia, nausea, and the patient can develop mouth sores. And again, if the patient has developed bleeding, possible transfusion with platelets can be done. You can refer to Table 1614 on page 274 in regards to the hematopoietic growth factors that are used to treat each of the side effects or with bone marrow suppression for your patients. We're now going to talk about neutropenia. This is an actual reduction in the neutrophils. And before we get to that part, please be aware that leukopenia actually refers to a decrease in the total white blood cell count, which includes your granulocytes, monocytes, and lymphocytes. Granulocytopenia is a deficiency of the granulocytes, which include neutrophils, eosinophils, and basophils. The neutrophilic granulocytes play a major role in phagocytation or phagocytizing pathogenic microbes and are closely monitored in clinical practice as an indicator for a patient's risk for infection. A reduction in neutrophils is termed neutropenia. The absolute neutrophil count, known as the ANC, is determined by multiplying the total white blood cell count by the percentage of neutrophils. Neutropenia is defined as an ANC less than 1,000 cells, because normally neutrophils range from 2,200 to 7,700 cells. Severe neutropenia is defined as an ANC less than 500 cells when calculated. In considering the clinical significance of neutropenia for your patient, it is important to know whether the decrease in the neutrophil count was a gradual or rapid onset, the degree of neutropenia, and the duration. The faster the drop and the longer the duration, the greater the likelihood of life-threatening infection, sepsis, or death for your patient. Other factors and comorbid conditions such as being older than 60, having an existing infection, being in a hospital setting, and having diabetes can also increase the risk of a more serious infection. Neutropenia is a clinical consequence that occurs with a variety of conditions or diseases. You can refer to Table 3122 for a list of these. It can also be an expected effect or a side effect of a patient taking certain drugs. The most common cause of neutropenia, as we know, is the use of chemotherapy and, of course, immunosuppressive therapy in the treatment of malignancies and autoimmune diseases. A patient with neutropenia is predisposed to infection with opportunistic pathogens and non-pathogenic organisms from the normal body flora. When the white blood cell count is depressed or immature, white blood cells are present, normal phagocytic mechanisms are impaired. Also, the classic signs of inflammation such as redness, heat, and swelling may not occur. White blood cells are the major component of pus. Therefore, in the patient with neutropenia, pus formation is also absent. When fever occurs in a neutropenic patient, it is assumed to be caused by infection and requires immediate attention. The immunocompromised neutropenic patient has little or no ability to fight infections. Thus, minor infections can lead rapidly to sepsis. The mucous membranes of the throat and mouth, the skin, the perineal area and the pulmonary system are common entry points for pathogenic organisms in those who are susceptible. Clinical manifestations related to infection at these sites include complaints of a sore throat and dysphagia. You may see ulcerative lesions of the pharyngeal and buccal mucosa. The patient may have diarrhea, rectal tenderness. In females, they may complain of vaginal itching or discharge. Overall, any patient can complain of shortness of breath, and they may have a non-productive cough. Seriously consider any minor complaint of pain or any other symptom by the patient and immediately report it to the healthcare provider. Minor complaints can progress to a much more serious condition leading to sepsis and septic shock if not treated early and appropriately. Be aware that neutrophils can also sometimes be referred to as segs or polys. Bands are immature neutrophils. Slide 19 shows you the actual calculating, or how you calculate the absolute neutrophil count. Slide 20 shows you your risk of infection based on the absolute neutrophil count and your ranges. When we look at your collaborative care, if an infection is suspected or the patient has a febrile episode, 2 blood cultures must be obtained and antibiotics started within an hour. Also, cultures need to be done from urine or any wounds if the patient has any. We look at their history and physical. We look at their white count with a differential count as well. In the lab, your pathologist will look at a smear to look at the white blood cell morphology. You also look at the hematocrit and hemoglobin values to see if there are actual signs and symptoms of bleeding or anemia. We will look at the platelet count. The patient may require a bone marrow aspiration if this is an unknown reason or onset for neutropenia. And as discussed, the cultures from any areas that have been ordered and a chest x-ray. Antibiotic therapy is important and prompt initiation is needed at any sign of infection, even when the patient has a low-grade fever of 100.4. Your growth factors may be necessary for the patient in order to help boost their white blood cell count and their neutrophils. It is very important to use strict hand washing and patient hygiene. These patients are placed in a single patient room with positive pressure or high efficiency particulate air filtration, depending on the risk, and that is based on their absolute neutrophil count. If it's an outpatient treatment that is occurring, community isolation and home precautions may be necessary. Understand your delegation decisions when you're caring for the patients with neutropenia. All members of the healthcare team have important roles in preventing infection in the patient. Careful hand washing is one of the most important measures and should be done before, during, and after patient care by everyone. As the registered nurse, you need to determine the type of isolation that needs to be initiated. Assess your patient for subtle signs of infection such as confusion or fatigue. Screen visitors for infectious diseases as they do not need to be visiting with the patient. Communicate with nutritional services to eliminate any undercooked meats from the patient diet. Instruct the patient and their visitors about hand washing. Teach the patient and their caregivers how to avoid infection, including the need for skin care and oral hygiene. If the patient is managed as an outpatient, teach them about the signs and symptoms of infection and when to report promptly to the healthcare facility or healthcare provider. The licensed practical nurse can administer antibiotics and the hematopoietic growth factor. They can check skin, oral mucosa, and perineal area for signs of infection, and monitor for signs and symptoms of infection and report them to the RN. Your unlicensed assistive personnel can obtain vital signs and report any changes to the registered nurse. They can assist the patient with oral care and their personal hygiene. The hematopoietic growth factors that are used, again, Neupogen or Neulasta, are utilized for white blood cells. These are granulocyte colony stimulating factors, and filgrastim is your generic term for that. For your red cell counts, Epigen or Procrit or erythropoietin or epoetin alpha is used for that. And again, the interleukin 11 platelet growth factor, Numega, can be used for your platelets and during thrombocytopenia. Side effects with these medications that occur include flu-like symptoms. One of the biggest things is these patients will have bone pain, and that is because of the stimulation to the bone marrow to produce cells, chills, and fever. These drugs are used to enhance or supplement the effect of the host's own immune responses to tumor cells. This table, slide 24, which is table 3124 in your book, reviews what you need to teach your patient and your caregiver in regards to care while your patient is neutropenic. Please review this for future reference and for the exam. Leukemia is a general term that is used to describe a group of malignant disorders that affect the blood and the blood-forming tissues of the bone marrow, lymph system, and spleen. Leukemia occurs in all age groups. It results in an accumulation of dysfunctional cells because of a loss of regulation in cell division. It can follow a progressive course that is eventually fatal if left untreated. Regardless of the specific type, leukemia has no single cause. It is now known that all cancers, including leukemia, begin as a mutation in the DNA of certain cells. Most leukemias result from a combination of factors including genetic and environmental influences. Abnormal genes or oncogenes are capable of causing many types of cancers, including leukemia. Chemical agents, chemotherapeutic agents, viruses, radiation, and immunologic deficiencies have also been associated with the development of leukemia in patients. The incidence of leukemia is increased in radiologists, those persons who live near nuclear bomb test sites or nuclear reactor accidents, and those who have been previously treated either with radiation therapy or chemotherapy. Leukemia can be classified based on acute versus chronic diseases and on the type of white blood cell count involved. The terms acute and chronic refer to cell maturity and nature of the disease onset. Acute leukemia is characterized by the clonal proliferation or immature hematopoietic cells. The leukemia develops after malignant transformation of a single type of immature hematopoietic cell followed by cellular replication and expansion of that malignant clone. Chronic leukemia involve more mature forms of the white blood cell, and the disease onset is more gradual. Leukemia can also be classified by identifying the type of leukocyte involved, whether it is of myelogenous or lymphocytic origin. By combining the acute and chronic categories with the cell type involved, one can identify 4 major types of leukemia. You have acute lymphocytic leukemia, acute myelogenous leukemia, chronic myelogenous leukemia, and chronic lymphocytic leukemia. Please refer to Table 3125 for the more defining features of these leukemic subtypes that are presented there. Acute myelogenous leukemia represents only 1/4 of all leukemias, but it makes up approximately 80% of all the acute leukemias in adults. It has an abrupt onset, and it is dramatic in its onset. A patient may have serious infections and abnormal bleeding from the very onset of the disease. AML is characterized by uncontrolled proliferation of myeloblasts, the precursors of granulocytes. There is hyperplasia of the bone marrow, and the clinical manifestations are usually related to replacement of normal hematopoietic cells in the marrow by leukemic myeloblast, and to a lesser extent to infiltration of other organs and tissue. The patient can complain of fatigue, weakness, headache. They may have mouth sores that are present. They will be anemic. They can have some bleeding tendencies. They can have a fever, infection, complain of sternal tenderness, gingival hyperplasia. They may also have mild hepatosplenomegaly. This can be found in 1/3 of the patients that present. With acute lymphocytic leukemia, it is the most common type of leukemia in children and accounts for about 20% of the acute leukemia cases in adults. In ALL, immature small lymphocytes proliferate in the bone marrow. Most are of beta cell origin. The majority of patients have fever at the time they are diagnosed. Signs and symptoms may appear abruptly, with bleeding or fever, or they could be insidious with progressive weakness, fatigue, bone and/or joint pain, and bleeding tendencies that may occur. There are some central nervous system manifestations that are especially common in ALL and represent a serious problem. Leukemic meningitis caused by arachnoid infiltration can occur in many patients that have ALL. In chronic myelogenous leukemia, it is caused by an excessive development of mature neoplastic granulocytes in the bone marrow. The excess neoplastic granulocytes move into the peripheral blood in massive numbers and ultimately infiltrate the liver and spleen. The natural history of CML is a chronic stable phase followed by the development of a more acute aggressive phase referred to as the blastic phase. The chronic phase of CML can last for several years and can usually be well controlled with treatment. Even with treatment, the chronic phase of the disease eventually progresses to the accelerated phase, ending in a blastic phase. Once CML transforms to an acute or blastic phase, it needs to be treated more aggressively, similar to the treatment for acute leukemia. The Philadelphia chromosome originates from a translocation between the BCR gene on chromosome 22 and the ABL gene on chromosome 9. The protein that is encoded by the newly created BCR-ABL gene on the Philadelphia chromosome interferes with normal cell cycle events, such as the regulation of cell proliferation. The Philadelphia chromosome, which is present in 90 to 95% of patients who are diagnosed with CML, is one of the diagnostic hallmarks. In addition, its presence is an important indicator of residual disease or a relapse in treatment. However, the presence of the Philadelphia chromosome is not specific to diagnose CML, since it is also found in ALL and occasionally in AML. In chronic lymphocytic leukemia, this is the most common leukemia in adults. CLL is characterized by the production and accumulation of functionally inactive but long-lived small, mature-appearing lymphocytes. Beta cells are usually involved. The lymphocytes actually infiltrate the bone marrow, the spleen, and liver. Lymph node enlargements is present throughout the body. Complications are rare in the early stages, but may develop as the disease advances. Pressure on nerves from enlarged lymph nodes can cause pain and even paralysis for the patient. Mediastinal node enlargement leads to pulmonary symptoms, and because this disease is mostly found in older adults, treatment decisions must be made by considering the progression of the disease and the side effects of treatment. Many individuals who are in the early stages require no treatment. Others may be followed closely and receive treatment only when the disease progresses. Approximately 1/3 will actually require immediate intervention at the time they are diagnosed. Although the clinical manifestations of leukemia are varied, they relate to problems caused by bone marrow failure and the formation of leukemic infiltrates. Bone marrow failure results from the bone marrow overcrowding by abnormal cells, by inadequate production of normal marrow elements as well. The patient is predisposed to anemia, thrombocytopenia, and decreased number and function of white blood cells. As leukemia progresses, fewer normal blood cells are produced. The abnormal white blood cells continue to accumulate because they do not go through the normal cell life cycle to death. The leukemic cells may infiltrate the patient's organs, leading to problems such as splenomegaly, hepatomegaly, lymphadenopathy, bone pain, meningeal irritation, and oral lesions. Solid masses resulting from the collection of leukemic cells, called chloromas, may also occur. A high leukemic white count in the peripheral blood, more than 100,000 cells, can cause the blood to thicken and potentially block circulatory pathways. This is called leukostasis and can be life-threatening for your patient. In order to do evaluation and to identify what is occurring with your patient, there are some very important diagnostics that are done. Peripheral blood evaluation and bone marrow examination are the primary methods of diagnosing and classifying the types of leukemia. Morphologic, histochemical, immunologic, and cytogenetic methods are all used to help identify the leukemic cell types and the stage of development. Identifying the type of leukemia is important because the various types have different prognosis and chemotherapeutic regimens. Other studies, such as a lumbar puncture and a CT scan, can detect leukemic cells outside of the blood and the bone marrow. The malignant cells in most patients with leukemia have specific cytogenetic abnormalities that are associated with distinct subsets of the disease. These abnormalities have diagnostic, prognostic, and therapeutic importance. Once a diagnosis of leukemia has been made, a collaborative care is focused on the initial goal of attaining remission. Age and cytogenetic analysis often help form the basis of important treatment decisions. Because cytotoxic chemotherapy is the mainstay of treatment, you need to understand the principles of cancer chemotherapy, including the cellular kinetics, the use of multiple drugs rather than single agents, and the cell cycle, which we have already discussed when we talked about chemotherapy and cancers from Chapter 16. In some cases, such as a patient who is non-symptomatic with CLL, watchful waiting with active supportive care may be appropriate. Although a patient may not be cured, attaining remission or disease control is a realistic option for the majority of patients. In some cases, cure is a realistic goal. When you talk about a patient being in complete remission, there is no evidence of overt disease that can be found on physical exam and in the bone marrow and peripheral blood. They all appear normal. A lesser state of control is known as a partial remission and is characterized by a lack of symptoms and a normal peripheral blood smear, but evidence of the disease may still be seen in the bone marrow. Minimal residual disease is defined as tumor cells that cannot be detected by morphologic examination, but can be identified by molecular testing. Molecular remission indicates that all molecular studies are negative for any residual leukemia. The patient's prognosis is directly related to the ability to maintain a remission. The patient's prognosis becomes more unfavorable each time they relapse. After each relapse, the succeeding remission may be more difficult to achieve and shorter in duration. Sometimes those patients who have a high white blood cell count, that initial emergent treatment may include leukapheresis and hydroxyurea. The purpose of these two treatments is to reduce the white blood cell count and the risk of leukemia cell-induced thrombosis. Chemotherapy is often divided into stages. There are 4: the induction stage, intensification, consolidation, and maintenance. In the induction phase, this is the very first stage, and it is the attempt to bring about a remission. Induction is aggressive in that it seeks to destroy the leukemic cells in the tissues, peripheral blood, bone marrow, to eventually restore normal hematopoiesis on bone marrow recovery. During induction therapy, a patient may become critically ill because the bone marrow has been severely depressed by the chemotherapeutic agents that are being used. Throughout the induction phase, nursing interventions focus on handling neutropenia, thrombocytopenia, and anemia, as well as providing the psychosocial support that the patient and the family needs. After one course of induction therapy, approximately 70% of newly diagnosed patients achieve complete remission. It is generally assumed that leukemic cells persist undetected after induction therapy. This could lead to relapse within a few months if no further therapy is administered. Post-induction or post-remission therapy. These terms are used to describe the type of therapy that follows, or used to describe intensification therapy. This is where our high-dose therapy may be given immediately after induction therapy for several months. Other drugs that target the cell in a different way than those administered during the induction phase may also be added. Consolidation therapy is started after a remission is achieved. It may consist of 1 or 2 additional courses of the same drugs given during induction or involve high-dose therapy. The purpose of the consolidation therapy is to eliminate remaining leukemic cells that may not be clinically or pathologically evidenced. With your maintenance therapy, this is a treatment with lower doses of the same drugs used in induction or other drugs given every 3 to 4 weeks for a prolonged period. Like consolidation or intensification, the goal is to keep the body free of leukemic cells. Each type of leukemia requires different maintenance therapy. You can refer to Table 3126 for the different types of regimens that are used with the different types of chemotherapy, or with leukemia. I will not be testing you on specific, but we may talk about side effects that can occur. Combination therapy is the mainstay for the treatment of leukemia, and it has 3 purposes: to decrease drug resistance, minimize drug toxicity to the patient by using multiple drugs with varying toxicities, and to interrupt cell growth at multiple points in the cell cycle. Newer therapeutic drugs are aimed at small molecules that promote the growth and differentiation of leukemic cells. For example, arsenic trioxide, which is used to treat acute promyelocytic leukemia, which is a type of AML, causes DNA fragmentation and cell death. In addition, it inhibits cell proliferation and angiogenesis, which is new blood cell growth or vessel growth, Imatinib, IMATINIB, targets the BCR-ABL protein that is present in nearly all of the patients who have chronic myelocytic leukemia. This drug kills only the cancer cells, leaving healthy cells alone. This is a type of targeted therapy. The use of specific targeted therapy in the form of monoclonal antibodies is an important treatment modality in hematopoietic malignancies, but cures with these therapies alone are rare. Other treatments that can be used include corticosteroids, and radiation therapy can also have a role in the treatment. Total body radiation may be used to prepare a patient for bone marrow transplantation, or radiation may be restricted to certain areas such as the liver and spleen or other organs affected by infiltrates from leukemic cells. In acute lymphocytic leukemia, prophylactic intrathecal methotrexate is given to decrease the chance of CNS involvement, which is common in this type of leukemia. When CNS leukemia does occur, cranial radiation may be given as well. Biologic and targeted therapy may be indicated for specific leukemias. When we talk about hematopoietic stem cell transplantation, this is another type of therapy that can be used for patients with different forms of leukemia. The goal is to totally eliminate leukemic cells from the body using combinations of chemotherapy with or without total body irradiation. This treatment also eradicates the patient's hematopoietic stem cells, which are then replaced with those of a matched sibling or other matched donor. The primary complications for patients with allogeneic hematopoietic stem cell transplantation are graft versus host disease. They can also have a relapse of their leukemia, especially those who had acute lymphocytic leukemia, and infection. Because hematopoietic stem cell transplant has serious associated risk, the patient must weigh the significant risk of treatment-related death or treatment failure with the hope of cure. Our overall goals for our patients are that they understand and cooperate with their treatment plan. They experience minimal side effects and complications associated with both the disease and the treatment that they will be undergoing, and that they feel hopeful and supported during periods of treatment, relapse, or remission. The nurse's role during acute phases of leukemia is extremely challenging because the patient has many physical and psychosocial needs. As with any other times or forms of cancer, there are significant evoked feelings of hopelessness, fear, and of fear of death. The patient and the family may need help and will need to be referred to support groups. The treatment and prognosis of each patient with leukemia, again, are driven by many factors, including their age, immunologic cell surface markers, and cytogenetics. Patients are not the same. Therefore, it is important that you have an understanding of the patient's particular type of leukemia, their overall prognosis, the treatment plan, and the goals. The family also needs help in adjusting to the stress of this abrupt onset of serious illness and the losses that are imposed by the sick role. Important nursing interventions include maximizing the patient's physical functionality, providing hope that acute symptoms of treatment are usually temporary, and encouraging patients to discuss their quality of life issues. Knowledge of drugs includes their mechanism of action, purpose, routes of administration, the usual dosages, potential side effects, safe handling considerations, and toxic effects. In addition, you must know how to assess laboratory data that reflect the effects of the drugs. The life-threatening results of bone marrow suppression require aggressive nursing interventions. Additional complications of chemotherapy that may affect the patient's GI tract, nutritional status, skin, mucosa, cardiopulmonary status, liver, kidneys, and neurologic symptoms or system. For a patient requiring long-term or maintenance chemotherapy, the fatigue of long-term chronic disease management can become arduous and discouraging for them. We're now going to discuss the lymphomas. Lymphomas are malignant neoplasms that originate in the bone marrow and lymphatic structures, resulting in actual proliferation of lymphocytes. Lymphomas are the fifth most common type of cancer in the United States, and there are two major types. There's Hodgkin's lymphoma and non-Hodgkin's lymphoma. You can review a comparison of the two types in Table 3128. When we talk about Hodgkin's lymphoma or Hodgkin's disease, this is about 11% of the lymphomas. It is a malignant condition characterized by a proliferation of abnormal giant multinucleated cells called Reed-Sternberg cells, which are located in lymph nodes. The disease has a bimodal age-specific incidence, it occurring most frequently in those who are 15 to 35 and those that are above 50 years of age. In adults, it is twice as prevalent in men as it is in women. Although the cause remains unknown, there are several key factors that are thought to play a role in the development. One of the main interacting factors include infection with the Epstein-Barr virus, a genetic predisposition, and exposure to occupational toxins. The incidence of Hodgkin's lymphoma is increased among those patients who have had HIV infections. Normally, the lymph nodes are composed of connective tissues that surround a fine mesh of reticular fibers and cells. When Hodgkin's lymphoma occurs, that normal structure is destroyed by hyperplasia of the monocytes and macrophages. The main diagnostic feature, as mentioned earlier, is the presence of the Reed-Sternberg cells in a lymph node biopsy specimen. The disease is believed to arise in a single location and then spread along the adjacent lymphatics. However, in recurrent disease, it may be more diffuse and not necessarily contiguous. It eventually infiltrates other organs, especially lungs, spleen, and liver. When the disease begins above the diaphragm, it remains confined to lymph nodes for a variable time. Those disease originating below the diaphragm frequently spread to extralymphoidal tissue sites such as the liver. And in this slide, you see the actual Hodgkin's lymphoma or the lymphoma tumor. This is a mediastinal node mass, and it is the second most common location. As you see here, you can see the enlarged lymph nodes. You can see the one from the back of the neck. The onset is usually insidious, as you see here. The initial development is most often enlargement of cervical, axillary, or inguinal lymph nodes. A mediastinal node mass, of course, is the second most common location, as mentioned earlier. This lymphadenopathy affects discrete nodes that remain movable and non-tender. The enlarged nodes are not painful unless they actually exert pressure on an adjacent nerve. The patient may notice weight loss, fatigue, weakness, fever, chills, tachycardia, or night sweats. A group of initial findings including fever, drenching night sweats, and weight loss are termed B symptoms and correlate with a worse diet prognosis. After the ingestion of even small amounts of alcohol, individuals with Hodgkin's lymphoma may complain of a rapid onset of pain at the site of the disease. The cause for the alcohol-induced pain is unknown. Generalized pruritus without skin lesions may also develop. Cough, dyspnea, stridor, and dysphagia may all reflect mediastinal node involvement. In more advanced cases, the patient may have hepatomegaly and splenomegaly. Anemia results from the increased destruction and decreased production of erythrocytes. Other physical signs may vary depending on exactly where the disease is located. For example, intrathoracic involvement may lead to superior vena cava syndrome. Enlarged retroperitoneal nodes may cause palpable abdominal masses or interfere with renal function. Jaundice may occur from liver involvement. Spinal cord compression leading to paraplegia may occur with extradural involvement, and bone pain occurs as a result of bone involvement. Peripheral blood analysis, excisional lymph node biopsy, and bone marrow examination, as well as radiologic studies, are important means of evaluating Hodgkin's lymphoma. Abnormalities in the CBCs, such as microcytic hypochromic anemia, are variable and not diagnostic. Leukopenia and thrombocytopenia may develop, but they are usually a consequence of treatment, advanced disease, or superimposed hypersplenism. Other blood studies may show hyperphoремia caused by excessive iron uptake by the liver and the spleen, elevated leukocyte alkaline phosphatase from liver and bone involvement, hypercalcemia from bone involvement, and hypoalbuminemia from liver involvement. Radiologic evaluation can help define all sites and determine the clinical stage of the disease. A positron emission tomography, or known as a PET scan, with or without CT, is used to stage and then assess the response to therapy, and also to differentiate residual tumor from fibrotic masses after treatment. These scans may show increased uptake and masses such as mediastinal lymphadenopathy, renal displacement that can be caused by a retroperitoneal node enlargement, or abdominal lymph node enlargement, and spleen, liver, bone, and brain infiltration. Using all of the information from the various diagnostic studies, the clinical stage of the disease can be determined. The final staging is based on the clinical stage and the presence of B symptoms. Treatment will depend on the nature and extent of the disease. The nomenclature used in staging involves an A or B classification depending on whether symptoms are present when the disease is found. Additional features that may move an early stage to an unfavorable prognosis, warranting more aggressive therapy, include an elevated sedimentation rate, age of 45 years or older, male gender, and the presence of a large mediastinal mass, and low serum albumin, hemoglobin, and low or high lymphocyte counts. Once the stage of Hodgkin's lymphoma is established, management focuses on selecting a treatment plan. The standard for chemotherapy is the ABVD regimen, which is doxorubicin or adriamycin, bleomycin, vinblastine, and dacarbazine. Patients with favorable early stage disease receive 2 to 4 cycles of chemotherapy. Patients with early stage disease but unfavorable prognostic features, such as with beta or B symptoms, or intermediate stage disease, are treated with 4 to 6 cycles. Those with advanced stage Hodgkin's lymphoma are treated more aggressively using 6 to 8 cycles of chemotherapy. The role of radiation as a supplement to chemotherapy varies depending on where the disease is at and if there is presence of resistance disease after chemotherapy. When you look at this slide, which is slide 61, you see how things look when they see a staging. Stage 1, you have one area of involvement. It's a single lymph node. Stage 2 is involvement of 2 or more lymph nodes on one side of the diaphragm. It is considered a stage 3 when there is lymph node involvement above and below the diaphragm, and stage 4 is when there is involvement outside of the diaphragm. The stage is followed by the letter A, meaning absence, or B, presence, to indicate the significant symptoms or systemic symptoms, such as does the patient have fever, night sweats, or weight loss. The next slides are just discussing some of the things I've already talked about in a previous slide in regards to the management focusing on the treatment plan to the least amount to achieve a cure and to minimize short and long-term complications. Again, they can use the combination chemotherapy, which can vary anywhere from 2 to 4 if it's an early stage, to in the advanced stages of a 6 to 8 cycle of treatment with chemotherapy. Intensive chemotherapy with or without the use of autologous or allogenic hematopoietic stem cell transplant may require the use of growth factors for the, to treat the symptoms of neutropenia, thrombocytopenia as well. We've already talked about radiation can be used. Response to therapy, again, is determined by follow-up CTs and PET scans, as well as bone marrow biopsies that can be done for the patient. Because therapy must be aggressive. Potentially life-threatening problems are encountered in an attempt to achieve remission. Occasionally, single drugs may be administered palliatively to patients who cannot tolerate the intensive combination therapy. One of the serious consequences of treatment for Hodgkin's lymphoma is the later development of secondary malignancies, as well as potential long-term toxicities from treatment that can affect the endocrine, cardiac, and pulmonary systems for the patient. With Hodgkin's lymphoma, again, there is the risk of the development of secondary malignancies after treatment. The most common are acute myelogenous leukemia, the development of a non-Hodgkin's lymphoma, and of course, your solid tumors. We need to think about with our nursing care of our patients for Hodgkin's lymphoma is based largely on managing problems that are related to the disease, such as actual pain related to the tumor. If the patient develops superior vena cava syndrome because they have a mediastinal lymph node involvement, pancytopenia, and other effects of the treatment that they're undergoing. Because the survival of patients with Hodgkin's lymphoma depends on their response to treatment, supporting the patient through the consequences of treatment is extremely important. The prognosis is better than that for many forms of cancer or leukemia, but psychosocial considerations are just as important as they are with leukemia. The physical, psychological, social, and spiritual consequences of the patient's disease must be addressed. Fertility issues may be of particular concern because the disease is frequently seen in adolescents and young adults, so these need to be addressed as well. Help to ensure that these issues have been addressed as soon or soon after the patient has been diagnosed. Evaluation of the patients for long-term effects of therapy is important because delayed consequences of disease and treatment may not be apparent for many years. We're now going to talk about non-Hodgkin's lymphoma. This is a heterogeneous group of malignant neoplasms that include primarily the beta and T cells or natural killer cell origin, and it can affect all ages. B-cell lymphomas constitute about 85% of all non-Hodgkin's lymphomas, and they are categorized by the level of differentiation, cell of origin, and rate of cellular proliferation. There are a variety of clinical presentations and courses that are recognized, from indolent, which is slowly developing, to rapid progressive disease. NHL, or non-Hodgkin's lymphoma, is the most commonly occurring hematologic cancer and the fifth leading cause of cancer deaths that occur. As with Hodgkin's lymphoma, the actual cause is usually unknown. Non-Hodgkin's lymphoma may result from chromosomal translocations, infections, environmental factors, and immunodeficiency states. Chromosomal translocations have an important role in the pathogenesis of many non-Hodgkin lymphomas. Some viruses and bacteria have also been implicated in the pathogenesis, including HTLV1, EBV, human herpes virus 8, hepatitis B and C. Environmental factors that have been linked include chemicals such as your pesticides, herbicides, solvents, organic chemicals, and wood preservatives. Non-Hodgkin's lymphoma is also more common in those individuals who have inherited immunodeficiency syndromes and who have used immunosuppressive medications, or who have received chemotherapy or radiation therapy in the past. Non-Hodgkin's lymphoma does not have a hallmark feature as that of Hodgkin's lymphoma. However, all non-Hodgkin's lymphoma involve lymphocytes arrested in various stages of development and may mimic a leukemia. For example, small lymphocytic lymphoma and chronic lymphocytic leukemia result from malignant proliferation of small B lymphocytes. with chronic lymphocytic leukemia having the majority of the disease within the bone marrow versus the lymph nodes. Diffuse large B-cell lymphoma, the most common aggressive lymphoma, is a neoplasm that originates in the lymph nodes, usually in the neck or abdomen. Burkitt's lymphoma is the most highly aggressive disease and is thought to originate from B-cell blasts in the lymph nodes. Non-Hodgkin's lymphoma can actually originate outside the lymph nodes. The method of spread can be unpredictable, and the majority of patients have widely disseminated disease at the time they are diagnosed. The primary clinical manifestation is painless lymph node enlargement. The lymphadenopathy can wax and wane in indolent disease. Because the disease is usually disseminated when it is diagnosed, other symptoms are present depending on where the disease has spread to. Non-Hodgkin's lymphoma can also manifest in nonspecific ways such as an airway obstruction, hyperuricemia, and renal failure from tumor lysis syndrome, pericardial tamponade, and the patient can have also GI complaints. Patients with high-grade lymphomas may have lymphadenopathy and constitutional symptoms such as fever, night sweats, and weight loss. The peripheral blood is usually normal, but some lymphomas actually manifest in a leukemic phase. So what do we do to help diagnose and stage non-Hodgkin's lymphoma? It is similar to how we stage and diagnose Hodgkin's lymphoma. However, because non-Hodgkin's is more often in extranodal sites, there are more diagnostic studies may be done, such as an MRI, to rule out CNS or bone marrow infiltration, or a barium enema or upper endoscopy. A CT scan can visualize for any suspected GI involvement. Clinical staging, as described for Hodgkin's lymphoma, is used to help guide the therapy. But establishment of the precise histologic subtype is extremely important. Lymph node excisional biopsy establishes the cell type and the pattern. Non-Hodgkin's lymphoma is classified based on morphologic, genetic, immunophenotypic, which is the cell surface antigens, and the actual clinical features. Treatment for non-Hodgkin's lymphoma involves chemotherapy and sometimes radiation therapy. Please see Table 3130. Ironically, more aggressive lymphomas are more responsive to treatment and more likely to be cured. In contrast, the slow-growing or slow-occurring lymphomas have a naturally long course but are very difficult to effectively treat. Patients with low-grade lymphoma may live 10 years or more without treatment. However, some initial therapies can be well tolerated and have been shown to reduce the time to progression of the disease. Lymphomas that are infectious-driven, such as H. pylori gastric lymphomas, may be treated with antibiotic or antiviral therapy. Hematopoietic stem cell transplant may have some benefit in certain subtypes of aggressive or refractory lymphomas. Rituximab, a monoclonal antibody against the CD20 antigen that's on the surface of normal and malignant B cells, can be used to treat non-Hodgkin's lymphoma. Once bound to the cell, it causes lysis and cell death. There are numerous chemotherapy combinations that can be used to try and overcome any resistant nature of the disease. However, complete remissions are uncommon, but the majority of patients do respond with improvement in symptoms. Other therapies that can be used include the monoclonal antibodies of Zevalin and Bexar. These are linked to radioactive isotopes. And also, again, they target the CD20 antigen that can be present on the surface of mature B cells and B cell tumors. Side effects of this type of treatment include pancytopenia for the patient. So they need to be taught about safety issues and how to minimize the risk of any radiation exposure to staff and to others. Peripheral T-cell lymphomas are treated similarly to intermediate grade or high grade B-cell lymphomas. So your nursing care is always similar to that for Hodgkin's lymphoma. It is largely based on managing problems related to the disease, such as pain, spinal cord compression, or tumor lysis syndrome that can occur, the pancytopenia, and any other side effects of the actual therapy. However, because non-Hodgkin's lymphoma can be more extensive and involve specific organs, it is important to understand the subtype and extent of the disease. For example, a patient with known involvement of the colon may complain of acute abdominal pain. The patient most likely would have abdominal guarding and an enlarged tympanic abdomen. This could indicate a bowel perforation and be considered a medical emergency. A patient with Burkitt's non-Hodgkin's lymphoma beginning chemotherapy would be at high risk for tumor lysis syndrome and would require frequent laboratory studies and monitoring, as well as strict documentation of intake and output. Any patient who's undergoing external beam radiation therapy has specific nursing needs as well. The skin in the radiation field requires attention. Concepts related to safety issues, again, we've already discussed back in Chapter 16 when we talked about radiation treatments. We also have to look at the psychosocial considerations, help the patient and family actually understand the disease process, the treatment, and the expected and potential side effects that are involved. Fertility issues need to be addressed with young patients who are still of childbearing age. And as in Hodgkin's lymphoma, evaluations of patients with non-Hodgkin's lymphoma for the long-term effects of their therapy are important because there can be delayed consequences of the actual disease and the actual treatment process, and may not become apparent for many years. Multiple myeloma, or plasma cell myeloma, is a condition in which neoplastic plasma cells infiltrate the bone marrow and actually destroy bone. This accounts for only about 1% of all malignancies and about 10% of hematologic malignancies. The disease is twice as common in men as it is in women and usually develops after the age of 40, with an average age being of 65 years. Multiple myeloma occurs in African Americans more commonly than in whites. Although it was not previously considered curable, many patients are living 10 or more years because of the variety of treatments that can be provided during the course of the disease. The cause of multiple myeloma is actually unknown, but it is possible that exposure to radiation, organic chemicals such as benzene, exposure to certain metals, herbicides, and insecticides play an important role. Genetic factors and viral infection may also influence the risk of developing multiple myeloma. The disease process itself involves excessive production of plasma cells, which produce immunoglobulins that normally serve to protect the body. However, when multiple myeloma, instead of the variety of plasma cells producing antibodies to fight different infections, myeloma tumors produce monoclonal antibodies. Monoclonal means they are all of one kind, which makes them ineffective and actually harmful to the patient. These monoclonal proteins, called M proteins, are made up of 2 light chains and 2 heavy chains. Bence-Jones proteins are the light chain part of these monoclonal antibodies. They show up in the urine in many patients with multiple myeloma. One of your diagnostic tests that they do to identify if someone has multiple myeloma is to do urine and look for Bence-Jones proteins. Multiple myeloma develops slowly and insidiously. The patient often will not manifest symptoms until the disease has become advanced, at which time skeletal pain is the major manifestation. Pain in the pelvis, spine, and ribs is particularly common and is triggered by movement. Diffuse osteoporosis develops as the myeloma protein destroys bone. Osteolytic lesions are seen in the skull, vertebra, and ribs. Vertebral destruction can lead to collapse of vertebra and ensuing compression of the spinal cord. Loss of bone integrity can lead to the development of pathologic fractures. Bony degeneration also causes calcium to be lost from bones, eventually causing hypercalcemia. Hypercalcemia can then lead to renal, GI, or neurologic manifestations such as polyuria, anorexia, confusion, and ultimately to seizures, coma, and cardiac problems. A serum hyperviscosity syndrome leading to cerebral, pulmonary, renal, and other organ dysfunction can occur in some patients. Even without this, high protein levels caused by the myeloma protein can result in renal tubular obstruction, interstitial nephritis, and renal failure. The patient may also display manifestations of anemia, thrombocytopenia, neutropenia, and immune dysfunction, all of which are related to the replacement of normal bone marrow with plasma cells. Neurologic abnormalities may be caused by regional myeloma, cell growth to compressing the spinal cord or cranial nerves, or by perineuronal or perivascular deposition. In slide 87, you actually see the multiple myeloma tumor that has occurred for your patient in the x-ray. You see it on the femoral area where they have actual a lesion present. There are 4 pathways to diagnose multiple myeloma. We do our lab studies, imaging studies, pathology, and our genetic studies. In our lab, we look at our serum protein electrophoresis, actually separate out the blood proteins and detect the presence of monoclonal proteins, which is indicative of multiple myeloma. A urine protein electrophoresis can also be done where we do a 24-hour urine. This is where the kidneys will excrete pieces of the monoclonal protein into the urine, which may indicate multiple myeloma, and this is where you see your Bence-Jones proteins. Your beta-2 macroglobulin test, this is referred to as a tumor marker for blood cell cancers, such as multiple myeloma, can assess for how many cancer cells the patient has and help to determine prognosis. Your patient will get a CBC, and most importantly as well, calcium levels will be done to see how involved, and also to treat for high calcium levels as well. Imaging studies used, we will do bone scans, and again, looking for the lesions actually present in the bone. You can do a CT, MRI, and the PET scanning, of course, is used for staging and to see how well the patient is responding to treatment. Pathology and genetics, they will look at a bone marrow biopsy as well for the patient. Collaborative care involves managing both the disease and the symptoms that occur because of it. Current treatment options include watchful waiting, corticosteroids, chemotherapy, targeted therapy, and hematopoietic stem cell transplant. Multiple myeloma is seldom cured, but treatment can relieve symptoms and actually produce remission and prolong the patient's life. Ambulation and adequate hydration are used to treat hypercalcemia, dehydration, and potential renal damage. Weight bearing helps the bones resorb some calcium, and fluids dilute calcium and prevent protein precipitants from causing renal tubular obstruction. Control of pain is one of your primary nursing management for your patient. When you're assessing your patient when they come in for follow-up, you need to make sure how well their pain is being controlled. Adequate pain assessment is very important. We also look, of course, at prevention of pathological fractures as well as management for the patient. Analgesics, orthopedic supports, and localized radiation can also help reduce any skeletal pain the patient is having. Bisphosphonates such as pamidronate, Zometa can also be used to inhibit bone breakdown and are used for the treatment of skeletal pain and hypercalcemia. They inhibit bone resorption without inhibiting bone formation and mineralization. These drugs can be given monthly by IV infusion for your patient. Radiation therapy is also another important component of treatment, primarily because of its effect on localized lesions. Surgical procedures such as a vertebroplasty can be done to help support any degenerative vertebra. Chemotherapy with corticosteroids is usually the first treatment that is recommended for multiple myeloma, as it is used to reduce the number of plasma cells. Initial treatment will depend on whether the patient is a future bone marrow transplant candidate and anticipated tolerance of therapy. The treatment usually includes a corticosteroid plus one or two therapies such as potentially or specific chemotherapy drugs. High-dose chemotherapy followed by hematopoietic stem cell transplant has evolved as the standard of care in eligible patients. Targeted therapy for multiple myeloma could also be used with certain types of drugs because these inhibit proteosomes, which are intracellular multi-enzyme complexes that degrade proteins. Proteasome inhibitors can cause these proteins to accumulate, thus leading to altered cell function. Normal cells are capable of recovering from proteasome inhibitors, but cancer cells undergo death when they are inhibited. Drugs can also be used to treat complications from the multiple myelomas, such as allopurinol to help reduce hyperuricemia, and IV furosemide that can promote renal excretion of calcium. Our major focus as nurses is related to the care of bone involvement and sequelae from bone breakdown. Again, maintaining adequate hydration is our primary nursing or one of our primary nursing considerations. IV fluids may be administered to attain a urine output of 1.5 to 2 liters per day. Although tumor lysis is rare, once chemotherapy is initiated, allopurinol may be given to prevent any renal damage from the uric acid accumulation. Because of the myeloma proteins, the patient is at an additional risk of renal dysfunction and electrolyte and fluid imbalances. Because of potential for pathologic fractures, use caution when moving or ambulating the patient. A slight twist or strain in any wrong way can actually cause a fracture in these patients. In addition, the development of peripheral neuropathy is common with several therapies for multiple myeloma and can contribute to the patient's discomfort. their inability to perform basic activities of daily living, and the risk for falls and injury. Pain medications and therapies can also lead to severe constipation for these patients. Pain management requires innovative and knowledgeable nursing interventions. Analgesics such as non-steroidal anti-inflammatory drugs, acetaminophen, or an acetaminophen-opiate combination may be more effective than opiates alone in diminishing bone pain. Braces, especially those for the spine, may also help to control the patient's pain. As in any pain management situation, assess the patient and implement the necessary measures to help alleviate their discomfort. You need to do a prompt and effective assessment for infection and make sure they have efficient and quick treatment for these patients with multiple myeloma. These recurrent infections may be due to the decrease in the production of normal immunoglobulins, the ineffectiveness of the overproduced and abnormal immunoglobulins. It could be due to the corticosteroids the patient is on, and or neutropenia that has occurred due to the bone marrow infiltration or side effects of treatment. Psychosocial needs require sensitive, skilled management. You need to help the patient and significant others adapt to changes that are fostered by chronic sickness and adjust to the losses related to the disease process, while also helping to maximize functioning and quality of life for the patient. The patient who has multiple myeloma can experience remissions and also exacerbations of their disease process. Patients may be on dialysis because of the myeloma-induced renal failure that can occur. Consequently, acute care is needed at various times during the course of the illness. The final acute phase is unresponsive to treatment and usually short in duration for these patients. The way in which patients and families confront death may be affected by the manner in which they have learned to accept and live with the chronic disease.